Hello, everyone. Welcome to Brainmap. This seminar series is co-sponsored by P41 funded Center for Mesoscale Mapping, housed in the Martinos Center. It's my great pleasure to introduce our speaker today, Judy Gichoya. Dr. Gichoya is an assistant professor in the Department of Radiology and Imaging Sciences at the Emory University School of Medicine. She's a multidisciplinary researcher trained as both an informatician and the interventional radiologist. Dr. Gichoya is a member of Cancer Prevention and Control Research Program at Winship Cancer Institute. She holds professional memberships with Radiological Society of North America, American College of Radiology, Society of Interventional Radiology, Society of Imaging Informatics in Medicine, and American Medical Informatics Association. I would just like to remind the audience, please address any questions using the Q&A box or raise their hands at the end of the talk. Dr. Gichoya, thank you very much for coming today. The virtual stage is yours.
Thank you for the invitation, and I hope everyone is having a good afternoon. So I selected this topic, the promise and challenges of harnessing collateral information from medical images using AI. And my motivation really was around, so when I got this invite to speak, previously, it was when we had published this paper that showed that we can identify self-reported risk from medical images. And so I just want to bring an overall, I will be discussing that paper in detail just because the people on the call really also think a lot about imaging and imaging acquisition and sequencing. And so I think that I want to go in depth in terms of that description because I believe that your feedback and thoughts can really help us move this work forward. And so I hope that you'll find this talk interesting. And my main presentation at the end of it is if I have, convinced you at least to bring your expertise to this area that I'm saying collateral information that we can, I think, figure out a newer way to do AI. So these are my disclosures, mainly around service and to many radiology societies, and nothing is going to be biasing this presentation. Like I mentioned, I'm going to discuss work that showed AI has superhuman abilities to detect patterns like self-reported risk. And then I'm going to dive more into sort of like our analysis that we thought would explain some mechanisms and explanations for this performance. And then really where I hope that you'll take away is the open research questions to be answered to harness this ability for better performing models. I've used this example here that shows like trends in medical imaging in the US and in one state in Canada. This is looking at 16 years. And, what they're saying is that all the images have plateaued, but really, if you think about the introduction of CT scans, MRIs, and I mean, now with nuclear medicine studies, is overall, there are millions and millions of studies that are performed every day. And it turns out that still this one, old saying, apparently it appeared in a 1913 newspaper advertisement that a picture is more than 1,000 words. It's actually true in the era of AI and medical imaging. And so I'll start off by describing this paper in a lot of detail. And this paper ended up being published in the Lancet Digital Health. And what we, just as a ground truth, because this can be very, very political, when we say self-reported risk, we are really referring to how the legal system and also how society sees you. So it's not, trying to think about biology or genomics and, genetic ancestry. That's not the scope of this presentation. And so we looked at how deep learning models perform to detect race from medical images, looked at anatomic and phenotypic confounders, and then I evaluated underlying mechanism. Now, if you have read this paper, you will see familiar things, so I apologize about that in advance, but I also intersperse new things and new feedbacks that we've received and some of the additional analysis. And so we use multiple data sets. We use, these are chest X-ray data sets, mimic chest X-ray, chest expert, and the Emory chest X-ray data set. And we also use the National Lung Cancer Screening Trial data set and the RESPECT subset from Stanford, because we needed the race labels, and this is what was for a PE challenge. We also had an Emory CT data set and a digital hand atlas. This is publicly available, an Emory mammograph. So we call this the embed data set. We've published about it, and a cervical spine data set. And really, we started off from a chest X-ray and then ended up finding this performance. Then we started wondering, does it work on other modalities? And this is how we ended up with all these data sets. Sometimes when you see the publication, it's lost into like how you ended up at that point. There's a variation of the percentages of people who are represented in these data sets. You can see, for example, in CheckSpot, there are only 4.8% of the patients who are identified as Black. And in the Emory data set, you can see we are close to 47%. And so this varies a lot across all data sets. And there are big sizes of data sets too. And so the first thing we did was train a model. And this work is inspired really around what happened to be just a very simple question. Like, I had attended a datathon the previous year as part of these activities that we organized, and this was in Singapore, and I realized that people are not using the mimic chest X-ray dataset, which was when it was, maybe 1 year old. And so some of the teams had worked on it, and so when the JACR had a special call for papers that would look at disparities, I said, hey, why don't we use the mimic data set? And we knew that we have differences in the racial distribution. And then our hypothesis would be that when we brought it to the Emory data set, all bias would be mitigated, and we'll see better performance. And our takeaway would be, yes, this is why, another reason why you need a diverse data set. And it turns out that it's not. When we did all our experiments, we'd see that, yeah, maybe for a certain specific condition, maybe you had a higher amplitude previously on the other data sets, but now that the amplitude has gone down when you bring to the Emory dataset, but the patterns persisted. And so that if you already biased to say cardiomegaly and it's favorable to Black patients, then the models are favorable to Black patients, then that pattern still persisted, although you could say that the number of patients affected changed when you changed your data sets. And so it's this concept that, when we're trying to figure out why we accidentally found, you could predict, what would be an equivalent of the race, self-reported race in this medical imaging. And so we thought it was a problem with the method, the model itself. So we kept changing the methods, and then we moved to the other data sets. And what we found is on chest X-rays, we have performances above 0.96 for the AUC for Black patients. This honestly occurs very early, just like at maybe the third or fourth epoch, which is just the cycle of training. And the performance is slightly lower for, other modalities, but it's still pretty impressive. The lowest is, the mammogram studies. But what we identified here was that that this ability, and this is not, by the time the paper was published, we had shared our model with multiple people. And when we took it to other places, this is what you want when you export your model, easy generalizability. And people were able to replicate our results, with surprisingly high performance. Now, I will tell you that we did take our project, the models actually, to the international scene, specifically the Taiwan, Chinese, and Japanese population. And the population that it performed the worst is the Japanese population, where we found there were a few samples, but these were around 0.3, which was something that we've never been able to really audit. And that's one factor is because of the number of studies available. The second area that we noticed here was sort of like, so I talked about better generalizability when you go to new sites, and I've sort of disclosed some of the places where we didn't see good results. And in terms of the training, this performance was achieved pretty early. So you can see a more detailed table of why this performance is there. The last thing that I wanted to mention about this is that when we had 6 radiologists on the job, and this really is a tough task for human beings, and we didn't perform very well. We were around 0.5 to 0.55. Now, I will point to some work that came from, teammates, Jeshri, who's left though, but, really showing that the saliency maps are not very helpful. And in this case, they were not. And there is upcoming work that we've seen, it's not in publication, from a group in Australia that's actually very promising in terms of thinking of explainability. And I'll tell you that this is still a big problem for this work. Here are more maps that show sort of looking at mammograms, splitting them, according to breast density. We know that this varies across racial groups, and trying to see what could the model be looking at, and also looking at the cervical spine radiographs. And these are pretty non-specific findings from as a medical imager. So Joshua Cohen, formerly from Stanford, had developed this explanatory tool. This was never included in the paper, but was subsequent, where you almost look at Gichoya, and there's a really good paper about this. And you're almost like stacking all the images of one condition, and then trying to assess, by looking at the encodings where the differences could be. So if I play the scene here, you'll see that the shoulders mainly are moving. It actually does very well. For example, in patients who have cardiomegaly, you can just see the heart is the one that's moving, and you'll be like, okay, that makes sense. We see more of the shoulders. So this is Asian, Black, and white patients. And, but the big hypothesis about this is that if we would be okay if the performance was only visualized on chest x-rays, but we know that when it went to other modalities, that we still saw the same performance. So you can't just say, oh, maybe it's your shoulders and then your hand. And so while this kind of gets us to a sense of where the differences could be, it's not very helpful ultimately if we think about the future use. Okay, so we then looked at image obscuration. Yes, we understand the saliency maps are not useful, but we do know that the models look at them as the areas that contributed most to the highest probability. So what happens when you mask out, blank out the highest, the hottest area of the saliency map, and in your test data set? And what you see is that the performance drops, but it's still better than humans, So there is some information, in the other parts of the image that is contributing to this. And we see this confirmed on these patch predictions, where we split the chest X-ray into 9 areas and zoom in on one patch, like 1-1, here, and use that for the training, and also just block and then use the other parts of the chest X-ray as the contributor. And using this, when we use this zoomed in one patch, we see the performance is 0.91, and when we block the area, the worst performance is here in the 3-2 patch, which is here. And if you've read chest X-rays, you know that this area just above the subxiphoid area can be very difficult and very varied in terms of how images are acquired. And we see that that's where when we sort of block this area, then we see a drop in terms of like the performance of the model. So we also looked at the image segmentation. Is this information localized in the subcutaneous tissues and on the soft tissues, or is it in the lungs? And so you can see the segmentations. This data set has now been published through Mimic if you want to use it. And we see that the lungs have lower predictions. It's still better than the humans, but the soft tissues have better performance compared to the lung, but it still doesn't match the original. So it's a combination of both lung and non-lung segments. We add noise and blurring. And this is a big takeaway for this work, and I'll show you a sequence of things that follow up here. And the reason for this is that on noisy images, we see a drop, and probably on the blood, Asian cohort is coming close to the human beings, but we see a big drop. So but it's surprising that even on these manipulated images, we still have some signal that the models are relying on. Now, I don't know if many of you know the text photo dataset, which is a picture of radiology imaging. It was really done to help out with sort of, the global south, when people are trying to maybe use WhatsApp to send images to each other. Could you use them for AI training? But we used them here to see, does this signal persist when you take a photo of a photo? And you can see this is the original predictions, and these are the ones on the text photo, better than humans. And so this is a little concerning, but we also know that the digital hand atlas is also a picture of a picture. And so even more worrisome that that signal is still present, because you may be thinking, well, maybe it's something just on the signal itself, and it could end up probably being, but so this was also surprising that it was different. We then changed the resolution of the images, and so we know that we feed the neural network different caliber of the images, but this 4x4 image is barely perceptible as a chest X-ray, and you can see that we still have 0.6 3 performance here, and 512 images, definitely what we feed into a neural network, or 256, and you can see sort of like where the performance is at that level. This, if you have TikTok, then you've probably played with adding filters on your images, and you know that you can modify them. This is addition of a high pass and a low pass filter, and here you can, I think this is the most surprising, because this high pass filter is barely perceptible as a, as a chest X-ray. And on this high pass filter, you still see you have close to 0.85 performance that the model can tell you where this image came from. Here are some experiments, some related work that's been done in terms of modifying. And this is just looking at augmentation, like when you start to change by rotating or shear transformation or scaling or fisheye distortion, do you change the imaging and what you see? And really all these augmentation techniques, we see very minimal impact in terms of like the race identification, and so not very, very useful to help us localize and figure out what's going on. One of the bigger issues that has come up is, well, maybe it's because we image a specific patients in a specific scanner, that we know that can happen, for example, with issues of BMI. And so what we narrow down is just look at a specific hospital with specific manufacturer, and then subsequently test the same model with other, with both, like a mixture of the equipment. And you see internal tests at the same hospital with same equipment. These are our AUC values. 0.92 is the lowest one here. And when we take it out, it drops to 0.86. But if you even just round out, this is not a significant change to say that it's because of an equipment specific thing that is causing that. We did some experiments working with our physicists here. We got a phantom. By the way, I didn't know, I was trying to even figure out, like, is there any form of melanin or just something on the phantoms that could, because we know that that's how images are, imaging equipment are calibrated, and to see, what could be happening. And when, subsequently, I'm not a phantom and physics expert, but apparently there has been quite a lot of innovation around phantoms. Initially they would use real bones, but now they have 3D printed bones. So you can imagine those are very, should not be having any information, in my opinion. And when, we acquired some sequences, varied the protocols, this ended up being CT chest. And what was even, because I expected that what would find is something, that peaks somewhere, in sort of like in the random area here of 0.5, but it turns out that some sequences, the model is very confident that some are black and some are white. And so, we see these two peaks at the very, very end. And so we've not been able to, it turns out that these phantoms are actually very difficult to acquire. And so we've not been able to really evaluate that theory further. And so we also looked at pixel intensities. Now, for the chest X-ray, they may not make the most sense, but if you're a radiologist and you've read a CT scan, we know that we always change the windows. And so what could happen when we change the windows and then use that, in sort of like as our data set? And what we find is that we got very random, AUC values for all pixel intensity thresholds. So, and this really was worked to, quite a lot of people think that it could be something to do with the bone density. And the early experiments we did were not very, I would say that there are people who spend their lives just removing bones from images. We didn't do that type of detailed experiment. And they say this is because, the bone is such high density that signal is very hard to remove. I've subsequently seen some formulas that, say, hey, this is a good bone density removal algorithm. And so maybe that may explain explain it, even, especially when you start to think about even the lung segments and the soft tissue segments, because that signal would still persist. But this was not what we found. But we've subsequently done work to look at the pixel averages across different ethnicities and races, just looking at just the pixel level data. And we published this in the SIM annual meeting. And what we see is that, the AUCs, when you look at the pixel level performance, is around 0.77, but we still see like there's an association between the intensity of the pixel levels and the self-reported rates. And when we use more traditional machine learning techniques like the gradient, boosted trees, then you can see that this pixel level intensity can be used to predict race. But I think what is interesting, apart from thinking that this signal is still persistent when the image structure is removed, is to start to think about translating this into explanations, and also rethinking about the impact of the, for example, the signal on an area. For example, if your model is not predicting pneumonia well for Black patients, could you use the pixel level data to discuss this? So I just put this here. It's a lot of results and work, and we're subsequently running this in a multi-center trial as a federated learning project. So we all know that the models fail on confounders. A lot of researchers from your team have published on this. And so this was a question that said, hey, what if you shuffle the labels in your test data set? And you can see that this was the distribution, predominantly white patients, a very little representation of Asian patients on the mimic data sets. And this is when you shuffle them, this is what we expect. This is what I expected from the phantom. This is what I expected from, this is where the humans performed. And so we find this random performance. Then we start to say, maybe the model is looking at, data set that cardiac patients have a lot of, heart disease. And so what if we look at just normal, normal chest x-rays, and, maybe it's predicting better these findings for patients who are older because they have comorbidities and the model learns that. Unfortunately, all these items, when analyzed alone or in combination, we do not find an association that the model is really relying on BMI or breast density or age or sex. And I mentioned a little bit about the bone density features, and we use this remove this by thresholding, but I do recognize the limitation of our approach, that other people have done better work in terms of just image manipulation. This is something else that's also not in the paper, like what's the impact? And, we now know that there's a RAD ImageNet, that's been released, I think, last month in radiology AI. And what we see here is that models initialized with ImageNets and trained for, end-to-end for race prediction, they perform better than the random weights. So I still don't see the relationship how like the birds and the cars, on the ImageNet affect this transference, but it turns out that, when you have, for example, if you have random weights initialization, that maybe the features are not planned well. I think also something else was just sort of this, what if you did a task to just predict AP and PA, and then you try and, just as a pre-processing task. And then we see that there's quite a drop in the performance of the models that are, this was an interesting task. We couldn't localize why this task was this way. And I'll show you specifically when we use like a transfer learning and look at the 14 chest x-ray labels, there's quite a lot of debate about this. But if you look at the performing pathologies that make it easier for you to transfer that race information, it tends to be cardiomegaly, edema, effusion, and support devices versus fracture and other pneumonia and other pleural diseases. So unfortunately, after many, many months, lots of teams and lots of feedback about this work, again, I said the most concerning part is that we still have this signal on these very manipulated images. And now, as we've looked at the pixel numbers, that may explain why. But we understand and still observe that we have this very, very high performance of deep learning models to detect race from medical images across modalities and external data sets. While we, despite analyzing multiple anatomic and phenotypic confounders, we don't see any confounding effect on this performance. And multiple experiments that have looked into this mechanism, do not explain why this finding or why this is possible. By the way, there was a paper that I was reviewing recently, not for a journal, just reading through, and it was hidden in the supplement material that they actually were able to use just EKGs for the same task. And so that for me, and I'll show you more examples, it's even more bizarre. And so this is why I'm moving more. This is just one aspect of what signal that is hidden in the medical images. What if we have a lot of hidden and collateral information in these medical images that we can harness? And this is going to be the next sort of shift of this presentation. This work by Emma Pearson is amazing. And what they do is develop an algorithm to reduce disparities in osteoarthritis. And this performs better than the Kellgren-Lawrence score. And it performs better for patients who are low-income earners, low education, and patients. Narrows the disparities even for race by just using this algorithmic severity score. And the way they do this is by creating a convolutional neural network, but also in the ground truth is the patient pain complaints more than just like the severity of the joint narrowing on the radiograph, which is really the KLG score. And this is pretty standard. And, they show that even not just saying, hey, this algorithm performs well, is that they start to look at the impact, the downstream impact for policy. Here, it's about eligibility for surgery. We know that this would affect coverage from insurance. And we see that the Black patients who become, when they use this algorithmic prediction score, the Black patients become, more eligible, and even patients who have lower income and lower education. And so we subsequently went back and analyzed this NIH dataset, which is what they use, and said, can we apply the our finding? So you have a finding here that's showing the ALP, the algorithmic prediction is better. And here we have a finding that is saying, hey, these models also encode the race signal. And if you look at this, we have pretty good performance for looking at this is the knee MRI and this is X-ray. So these are different modalities. And for MRI, 0.92 and 0.99 really for detecting the race. So the question that I have to pose to you is the prediction here just because the model gets better at identifying which patients, are Black and narrow and eliminates that, or is relying on that signal to get better prediction? Or is this approximation as a confounder that really may break it as we start to see the change in demographics, where many patients identify as mixed race, or people from maybe Turkey who may not really want to identify in any of the traditional groupings that we have seen. And so this is really the conundrum of how do we harness this collateral information. It's October. If you have your mom, your sister, your daughters, your wife who's eligible, you should really make sure that they're getting their mammogram this month. And what we know that the breast cancer outcomes are terrible for minorities, both Blacks and Hispanics. They tend to have more invasive disease at younger ages. They are usually diagnosed at advanced breast disease age, and they're more likely to have this advanced disease when they're younger. And this year, I think they just said that the cancer deaths have plateaued. And so this is really, a terrible thing, I think. And so, and we know, well, we may not know, but Nancy Capello is someone who really changed how, regulation around breast cancer and notification. And so she had dense breasts, had always had an annual mammogram, and she had a mammogram 6 weeks earlier, then felt a lump and came in as, coming with breast cancer, but yet the mammogram was read as negative. And so she was told, yeah, you have dense breasts. And so, you could, like this can hide cancers, and she was very devastated and started to, change that this regulation that if you have breast density, then you should notify the patients and you should offer them more additional screening mechanisms. So this idea of screening for a cancer that's actually well matured in terms of treatment remains still a tough task in today's world. And so this is the Mirai model developed by the MGH team and also inspired by Dr. Regina Basile, who's also a breast cancer survivor, amazing computer scientist. And what they do is put in all these images alone, encode them, aggregate their results, and then if you have clinical information, use that as risk a predictor to give you breast cancer risk at 3 years and 5 years. And so what is important here is to realize that there's an arm here that does not require any clinical information. This model has been subsequently validated, actually including Emory team here. This is the state of the art today, where we have these Gale models that are Kuzik, and subsequently now you can see that the earlier models did not have breast density included, but now everyone understands that that's a risk. And we have all this clinical information. And if you think about this, for example, my family, I would never be able to get this history from my grandparents. And so, or some patients may not come for screening every year. And so if you had a model that performed pretty well, whether it had this information or not, and this is what the Mirai model says, at least that's what it was designed, how it was designed to work, then this starts to tell you that, I may not really understand, I just put this as an example here, but it doesn't tell you where the breast cancer is going to come, it just tells you the risk of the breast cancer. But when I look at this image and you tell me there's a risk of breast cancer, I'm not seeing anything. I mean, what's the AI model looking at, and how obviously we will need a lot of prospective value studies for this, but I think we're starting to see the promise of what these models could look like. Just for reference, the Tarakuzik model is terrible, and it's even worse for Black patients, and you can see what the Mirai model performs relatively to the gold standard. So changing a little bit to other examples, here's an example looking at racial ethnic disparities using deep learning from chest x-rays. And here what it just says is that absence of a code is a health disparity. For example, if I'm in the hospital and you don't say I have congestive heart failure or diabetes, then if there are other programs that could help me, or change of medication, or all these other sets of decision support that depend on it, then they tend to be broken. Now, as the healthcare system in the US is trying to move to a value-based system, we have these hierarchical codes. And all this do is that they group all the diseases together and try to say, okay, this is diabetes with acute complications, and they're just trying to bundle the payments. And so what we subsequently did here was train a convolutional neural network on hierarchical conditions, and then start to see what can we tell from this. So you can see that here, just from the left here, we have diabetes, obesity, cardiac congestive heart failure, arrhythmias, vascular disease, and COPD. And then we start to look at where is this model looking at, and it's not unusual to know that the models can predict demographic information, for example, age. And so we find good performance. The congestive heart failure is looking centered more around the heart, same to arrhythmias as you would expect. Obesity is both subcutaneous tissues around the heart, just everywhere. And COPD can affect, the heart and the lung systems. Vascular disease looking more at the mediastinum and the aortic arch, and then diabetes, sort of everywhere, including the subcutaneous tissues. And so we subsequently actually add something else, the social deprivation index. And this is a metric that combines demographic data of poverty, high school dropouts, renting, overcrowding, lack of car ownership, and employment into a granular zip code level ranking. And you can use this to identify healthcare deserts. And so we then use this essentially to understand further how we split our cohorts. The performance of the model is actually pretty good. This can vary from 0.76 to 0.90. Let me show you a practical example here, where this is the history. 65-year-old self-reported Hispanic Spanish speaking woman with who was COVID positive and without a diagnosis of congestive heart failure. This is just to tell you, if you've been in the hospital and you have to use a translator to acquire all the images, your records are most likely going to be incomplete. And in this case, yes, there's a big heart. And when we went back to do the chart review, we found that this is a patient with a history of diabetes, non-compliant with medication, has social deprivation index is 49, which is high, and had an echocardiogram actually ordered in 2019, but was never completed. And so this is what sort of just looking at images, and now I can start to complete your medical record or get codes, and I will show you in a few minutes what some other people are using here. Here's an example that's just also relying on chest x-rays to look at future healthcare expenses. I think this is, this can be very dangerous territory. And so they look at what's the prediction at 1 year, 3 year, and 5 year expenses. In my notes today, as I was just browsing, I realized that Apple is predicted that they're going to be a healthcare provider, a healthcare insurance provider by 2025, and they're going to rely on all this data that they collect from your Apple Watch. I do have one, and I think for me that's like surprising and also concerning, because these models we're starting to see this type of work being used for insurance underwriting. In this case, they provide some examples. Here is a patient. This I would have called a normal chest x-ray, but the predicted cost, the actual cost was $13.25, the predicted cost here. So, not much difference. And then this is a patient who has a pot. So you know that this is most likely a cancer patient or someone who requires a lot of healthcare. And you can see, even if the saliency map is a little off, this is where, as a radiologist, this is what I would look at. And the predicted cost was 68,000. The actual cost was 70,000. So this is someone who's predicted to have lower cost. This is higher cost. These are some bad predictions. Here you can see some multifocal opacities, could be pneumonia, and this predicted cost ended up being close to 11,000, but that was not what ended up happening. And this is someone who was predicted that they would have a lower cost. You can see maybe they have an ectatic aorta, so likely a little bit of an older patient, but they ended up with a high cost. And so still unpacking what this means. This is a group that looked at deep learning to estimate biologic age from chest radiographs. It's not unusual that we understand aging differently. When you go to a patient's room, you may see, wow, that they're pretty young, and and just on their imaging, but in face that they're actually way older than you expected. And so this discrepancy is not unusual. This group looked at chronologic age and biologic age, and as a matter of looking at outcomes. And they were able to use, again, a convolutional neural network and feed in what would be the chest x-ray age. And then they have a chronologic age, and then they have this outcome, which is, for example, this patient, the age is, the chronological age is 71, but the chest x-ray says they're younger, but they're still alive at the end of 94 years. They use the prostate, lung, colorectal, and ovarian cancer screening trial dataset, because you need normal chest x-rays and for a long time, and also the national lung screening trial. And most importantly, these patients were largely healthy and never hospitalized, and these images were normal. And so you can look at some where the chest x-ray age is greater than the chronologic age. So it's just saying that you're older, and you can see this patient died from cardiomyopathy, died of stroke, died of ischemic heart disease. And this is the reverse, where it says you're younger than you really are in terms of the numbers. And you can see what ended up with this in terms of like the alive at what age it is. And not unsurprising that if you've had to have insurance, that they send a nurse to your house and they get all this blab. But if I can start to use this chest x-rays to tell you the healthcare cost, your biologic age, and your ICD code, you could start to see this conundrum where, why do I need to send a nurse to your house? And we will see this change even how we do insurance underwriting and decide who gets coverage or not. So in conclusion, can we harness hidden signals on medical AI imaging using AI? I want to put back and just say, remember, there's a widespread use of imaging. These hidden signals could be biomarkers. We still need a lot of work to figure out why they matter. There's actually potential for multimodality data merging, which is, I think, interesting. Most of the cases that I've shown you, except from the knees and the mammograms, they are mainly chest x-rays. We could also have less human curation, as we've seen, for example, with body composition, calcium scoring. Those are starting to be pretty standard. It's cost effective, especially if the imaging is being done for something else, and we know that the radiation is actually going down. And even challenges us to think about new use cases, for example, completing data sets for clinical trials. Other people have suggested that we could start to use some of this work. I got a lot of emails around this for forensic pathology. And so I put this here as a group. This group does quite a lot of work in terms of looking at automated body compositions markers. So you're already acquiring images, you're just running these algorithms on the background to capture more information. But what could challenge the success of this work is that we understand that there are already discrepancies in how we image. Not all chest pains are equal. Black, Hispanic, and non-white patients are less likely to undergo diagnostic imaging in the AAD. So as we start to scale these technologies, we still have to understand what biases exist. Some can be at the hospital level. For example, if you have a minority serving hospital, or one hospital is really responsible for a specific subgroup of patients. Explainability, I've shown you many examples. I've tried to interpret them as from the point of a radiologist, but we know that this remains a big challenge, and that we still don't have enough data sets, and we also don't understand what's the appropriate composition to make these fair models. And the data sets that exist out there lack a lot of granular information that will be important for us to harness. And so we have to do this with an ethical landscape, and wearing our ethical hats to be able to harness this potential for our patients. And it cannot be done by one person, requires diverse data, diverse teams, and is from the point of problem selection up to the post-deployment considerations. Again, I appreciate your time and invitation. We're always looking to hire if you want to move to a warmer area. And I thank you again for your attention.